Welcome to Mental Health Playbook Same-Day Billing and Bundling. My name is Karen Curtis. I am a member of the WPS Provider Outreach and Education team, and I will be your presenter. Joining me is my friend and coworker, Mary Muko. Mary's going to be helping me today by monitoring the chat and providing you with additional information and links. You've seen she's been adding stuff as we've gone through this introduction, links, things like that, just to help you. If you have been checking out our live events page, you may have noticed multiple webinars beginning with Mental Health Playbook. These sessions are designed to give an entry-level introduction into Part B mental health. Previous sessions can be found on our Encore Presentations webpage as well as our YouTube channel. Now, listening to the previous sessions is not something that is required to understand what we will be covering today. I just wanted to make sure that you are aware that there is additional education available. Now, I hope by the end of this webinar that you will have a better understanding of Part B mental health same-day billing guidelines. We're also going to take a look at the National Correct Coding Initiative edits and how to use that edit spreadsheet. Now, at the bottom of this slide, you will find a reminder to review the disclaimers at the end of the presentation. The first one reminds you that Medicare's rules change often. And so the CMS website should be something that you check for the most updated rules and information. Also, because some of the material being shown today does contain CPT codes, the second disclaimer lets you know that those codes are copyrighted by the American Medical Association. Now, the CMS Medicare Learning Network provides a lot of great educational material that, in my opinion, puts their guidance in a format that is easier to understand than trying to read the internet-only manuals. So this is something that that I will refer to during today's presentation is information that can be found on the Medicare Learning Network, so I wanted you to know where it is. Also, as Mary and I work through our webinars on mental health, we will refer to the MLM booklet, Medicare and Mental Health Coverage. On this slide, you will find some of the topics covered in this publication, and although it is not listed here, this booklet does contain some information regarding same-day billing. We will take a look at a couple things in this booklet when I'm answering some questions later. So we're going to start out today by going over some guidelines. So when we mention same-day billing, we are referring to reasonable and necessary services that are provided on the same day to the same patient. The professionals providing the services may be the same or different, and the location where the services are received may also be the same or different. Now, in the MLM booklet mentioned earlier, CMS discusses same-day billing for primary health care services, mental health care services, and alcohol and substance abuse other than tobacco structured and intervention services. Medically reasonable and necessary is a phrase that you will hear a lot in Medicare. Services provided to a patient must be reasonable and necessary for the diagnosis or treatment of an illness or injury or to improve the function of a malformed body member. This is based on language found in the Social Security Act. A link has been provided in case this is something that you would like to learn more about. Now, you may be wondering how contractors determine if a service is reasonable and necessary. Some things to consider are whether the services are proper and needed for the diagnosis or treatment of a medical condition. Were they provided for the diagnosis, direct care, and treatment of a medical condition? And finally, do the services meet the standards of good medical practice and are not provided for the convenience of the patient or the provider? Now, services must also meet any national or local coverage determination policies. This slide contains a link to the Medicare coverage database. If you aren't familiar, this database provides a centralized, searchable repository for all the Medicare coverage policies. It allows providers to search for a particular item or service and determine if Medicare has any related national coverage determinations or local coverage determinations. National coverage determinations, or NCDs, are going to apply to all providers regardless of jurisdiction. Local coverage determinations, or LCDs, are policies written by a MAC regarding whether or not a particular item or service is covered within that MAC's jurisdiction. So this is something you're going to want to pay attention to when you're searching for coverage guidelines. You don't want to follow coverage criteria that's in an LCD that's written by NGS if you're submitting your claims to WPS. Since we have some providers that indicated that they were new to billing during the registration for this course, let me show you what I'm talking about. So let's go out real quick. I have the Medicare coverage database, and if I search, let's just say for psychiatry, we're going to see that there are LCDs put out here by different contractors. So CGS has one, NGS has one, and WPS has one. So if you're submitting a claim to WPS, you want to make sure that you are looking at the policy that's written by WPS, because that's what our medical review department is going to look for. Now, WPS has held a webinar specifically on how to navigate the Medicare coverage database in July of 2025 as part of our Medicare Education Expo. So I will have Mary add a link to that Encore presentation in the chat. That way, if you aren't familiar with using that database, that will kind of help you with that. Now, when we were just looking at the database, you could see that WPS does have a local coverage determination, which is LCD L34616, and that is for psychiatry and psychology services. Now, along with that is an article, which is A57480, and this was written to go along with the policy. So this article is going to address general coding, service-specific guidelines on certain CPTs and HCPCS, billing guidelines, as well as other information. Now, Mary did hold a webinar earlier this month, and she went over not only the LCD but also the article. So she did cover this information in detail. If this is something that you would like to know more about, that Encore presentation is available on our Encore Presentations webpage and our YouTube channel. Now, another term that goes along with medically reasonable and necessary is otherwise covered by Medicare. So for services to be considered for payment, you want to make sure that they're not duplicate charges, that they should meet statutory requirements, and claims should be submitted by eligible providers for eligible beneficiaries. Finally, they should be coded correctly. And, that's something that you'll want to make sure that the documentation supports the codes that you have on the claim. Now, there are some services that will always be bundled. There are some items and services that won't receive separate payment from Medicare. The reason is because the payment of this item or service is already included in another service that was performed on the same day. Now, to find out if a code is considered an always bundled code, you can refer to the physician fee schedule relative value file and look at the status code column. We will go out there. I'm going to show you some examples of what you're going to look for here. Now you can use the search function, but I'm also going to show you how to navigate. So from the cms.gov website, we're going to click on Medicare, Payment, Fee Schedule, and here we have the physician's fee schedule over here. Now if we scroll down, we have the physician fee schedule relative value files. Now these are, the physician fee schedule relative value file is the basis of Medicare payment for all services. I went ahead, these are very large files, so I went ahead and downloaded the files earlier so that you didn't have to wait for me to have all that time wasted with it trying to load. So here on the the physician fee schedule relative value file, you will see the first column is going to contain the HCPCS or the CPT codes. Then that second column, we're going to have modifiers. So there may be modifiers associated with the code when you're looking those up. Next, we have the description. But what we really want to look at is we want to look at that column D, the status code. Now, if that status code, I have one highlighted right here, the status code right here is a B. So if you have a code that contains the letter B as in boy, P as in Paul, or well, let's talk about B and P first. These services are always going to be bundled into the payment of another more comprehensive service. In these situations, it would not be appropriate to request an appeal because this service is always bundled and Medicare is not going to make payment on it. So an example would be a code that you may be using is 99024. So if I click on this and do a search for 99024, it's going to show me that that's an always bundled code. Now, if there is a code that has a status code of T as in Tom, they are only paid if there are no other services payable under the physician's fee schedule that is being billed on the same date by the same provider. If any other services payable under the physician fee schedule are billed on the same day by the same provider, then those services are going to be bundled into the physician services for which the payment is made. So those are the status codes you're going to want to look out for. B as in boy, P as in Paul, T as in Tom. Now here you're going to see some considerations that CMS uses when determining whether a service or an item will be defined as a bundled service. CMS is going to look at policies based on coding interventions and what's defined in the AMA CPT manual. They're also going to look at national and local policies and edits, so those NCDs and those LCDs that we talked about earlier. Coding guidelines developed by national societies, standard medical and surgical practices. What is the standard in that locality for that particular item or service that is being rendered on the same day? Finally, CMS is going to review current coding practices. So all of this is going to be considered as to whether they think a code should be bundled. Now the CMS Physician Fee Schedule Lookup tool is another common tool that is used by providers. I have included a link. Now using this tool, they do have, let's go out there real quick. You will use to find this, you will have to begin a search, and then you do have the license that you will need to agree to. Now here you can select different information, so pricing, payment policy indicators, relative value units, and geographical practice cost index. You simply enter the code you're looking for, and you see there's multiple drop-down boxes where you can um, narrow those results down. Now I have found that when I search for codes that are bundled, you are going to get a message that those codes aren't on here, which, I mean, it kind of makes sense. We're not reimbursing it. So if you're looking at payment or pricing, you're not going to find something like that. So if you use this and you look for a code and it comes up that it's not there, you would probably want to go back to that spreadsheet that we looked at earlier to determine if it is a bundled code or not. So next we want to talk about the NCCI PTP Edits, which is the National Correct Coding Initiative Procedure to Procedure Edits. Um, the NCCI program was originally developed for Part B claims that were billed on the CMS 1500. But in 2000, many of the edits were added to the outpatient code editor to process Part B outpatient hospital services. These edits are meant to apply to services billed by a single provider or supplier for a single patient on the same day of service, and it does affect all Medicare contractors. These edits do not include every possible combination of codes or types of unbundling, so providers and suppliers have a responsibility to make sure that they are coding correctly even when an edit does not exist. Today we are going to take a look at the procedure to procedure or PTP edits. Now, the goal of procedure to procedure edits is to prevent improper payments by ensuring that Medicare is not paying for services that are bundled or should not be reported together. Understanding the principles allows providers to avoid coding errors and potential denials. Procedure to procedure edits also reduces administrative burden. These are automated prepayment edits, so it reduces the need for manual reviews and appeals. These edits look at pairs of HCPCS or CPT codes that should not be reported together for reasons such as being mutually exclusive or part of a larger procedure. Now, there may be times when it is clinically appropriate to build the two codes together. When that occurs, you're going to want to include the appropriate NCCI associated modifier. You're also going to want to make sure that this is documented within the patient's medical records. And when we look at the edit files, you're going to notice that each table has two columns. So we have column 1 that's going to show the payable code, while column 2 is going to show the code that isn't payable with the column 1 code, unless an associated NCCI modifier is permitted and included on the claim. Now, CMS posts changes to each of its NCCI PTP published edit files on a quarterly basis. This is going to include additions, deletions, and modifier indicator, all on on a quarterly basis. Because there is a large amount of data, the files are zipped. So this means that you will have to download the file to your computer before it can be unzipped. You will not be able to view the tables directly from the website. Now, again, because the files are so large, they have been broken down into 4 different zip files, and those are based on HCPCS or CPT code ranges. So it's not so cumbersome. You will want to make sure that you are downloading the correct file based on the code you're looking for. The files are also divided into those that are related to hospital services and those that are related to practitioner services. Now, if you are new to Medicare or if you are new to the NCCI tables, CMS has created a Medicare Learning Network booklet to help. A link is included on this slide, but it can also be found on the CMS Medicare Learning Network webpage. This booklet does provide a background on the NCCI edits, as well as how to use the tables for not only the procedure to procedure edits, but it also covers medically unlikely edits and add-on code edits. Now here I've included a portion of the procedure to procedure code pair table. We're going to take a closer look at it, but I wanted to at least introduce it here. Each spreadsheet has a column A and B. If a provider reports the two codes for the same beneficiary on the same data service, column A is eligible for payment and column B is denied unless an appropriate modifier is not only allowed but is present on the claim. The next column is a edit status prior to 1996. You may be wondering why anyone would care about the status of an edit prior to 1996. And it probably doesn't matter to most of us, but in 1996 was the year the NCCI program was officially implemented. So this column just helps keep track of edits that were already in place prior to the program's existence. Column D shows the edit's effective date in a year, month, day format. Column E is in case there is a deletion date. This is also in a year, month, and day format. Column F is going to let you know if a modifier may be appropriate. This column will contain one of three values. A 0 lets you know that there are not any modifiers associated with NCCI that will allow you to use this code pair. When no modifiers are allowed, only the code listed in column A will be payable. If there is a number 1, this means that a modifier can be used with the code pair when appropriate. The last option is number 9, and this appears when code pairs have a deletion date that is the same as their effective date. Now the last column, or column G, provides the category that gives the rationale for the edit. CMS uses this to describe a group of codes that should not be reported together. This isn't to say that these codes can never be billed together, but there may be limited circumstances where a modifier would be allowed. You can also see CPT manual or CMS manual given as a reason under that rationale, and that's going to let you know that there's instructions somewhere, either in a manual, either a CPT manual or a CMS manual, that's going to give you instructions as to why those codes aren't allowed. Another rationale can include standards of medical surgical practice and mutually exclusive procedures. Now, modifiers should only be added if your claim if the clinical circumstances justifies using them and your documentation must support the decision. They can be used to provide additional information regarding the billing situation. Modifiers can explain what procedures were performed on a different anatomical site. Um, Maybe a laboratory test had to be repeated, or maybe you're billing for a separate procedure or encounter. It is important to remember that not all modifiers can be applied to NCCI scenarios, but proper use will allow the claim to bypass edits. Again, it's never appropriate to add a modifier to a claim just for the sole purpose of bypassing an edit. Now, different modifiers are appropriate for different situations. There are anatomical modifiers. These may be used if a code pair is possibly subject to the procedure-to-procedure edits, but they're performed on different parts of the body. So an example would be RT and LT, which identify the right and left side of the body. There are modifiers that identify specific digits on the hand and feet. There's even modifiers that distinguish which eyelid the service is being performed on. Global surgery modifiers are used to indicate specific situations within the global period of a surgical procedure. They can clarify if a service is being performed as preoperative, intraoperative, or postoperative. Other modifiers can report that a procedure or service was distinct or independent from another service that was performed on the same day. One of the examples could be if there's two procedures on the same anatomical site, for an elbow, but two different incisions with two different procedure or CPT codes were used. So things like that, you would want to use a modifier to explain why the codes are being billed together. Of course, first you would need to check the procedure to the procedure edits to determine if an appropriate modifier is allowed. If yes, then you'd move forward trying to find the appropriate modifier that fits your specific situation. Modifiers can also be used to show there was a separate encounter with the patient on the same date of service. Maybe a service was performed by a different practitioner or on a separate organ or structure. Now, if you need help determining what modifier may be appropriate, WPS provides a lot of resources related to modifiers. The slide here contains a link to the CMS resource for modifiers 59, XE, XP, XS, and XU. But I did want to show you what WPS also has to offer. So if we go out to our website, right over here under the quick links, you'll find modifiers. And now you will want to make sure that you are in the correct jurisdiction because that can change the options that are the resources that are available. But I just wanted to let you know this is out here. And as you can see, we really do have a lot of fact sheets on quite a few modifiers. So that is another option. You can check CMS's website, but this is also a good option that has a lot of resources. So in general, if both codes in an edit pair are submitted for the same beneficiary on the same day of service, the column 1 code is eligible for payment and the column 2 code is denied unless, of course, that modifier is appropriate and reported. You will want to make sure again that the patient's records explain why it is appropriate for the patient to receive both of these services on the same day. Now, we've talked a lot about documentation, so here are some examples of questions that you can ask yourself to make sure that you are coding your claim correctly or that your documentation justifies use of a modifier. One thing to remember when asking, does documentation justify the codes being reported together on the claim? So were they rendered by the same person to the same beneficiary on the same day during the same encounter? And when I'm talking about the same person, when it is an organized clinic, what we're talking about here is the same person equals the same specialty. So if there's two specialists working in a particular department, and they see the same patient, it is considered one provider. So that is also something that you'll want to keep in mind. Now, one thing to keep in mind, services that are denied due to NCCI edits, these are based on correct coding, not medical necessity. So this means that an advanced beneficiary notice of non-coverage would not be applicable in these situations. These denials are considered provider liable, and if we think about it, that makes sense. Um, they're considered coding errors, so that's not something the beneficiary would be responsible for. Now, if you do find that you need to make a correction, here's some steps to take. First, determine if a procedure to procedure edit applies to your service by reviewing the edit tables. Check column F to see if there's a 1 indicating that a modifier could be appropriate. Verify that your documentation supports the use of billing both codes and using the NCCI associated modifier. For Part B claims, you can resubmit only the denied service with the appropriate modifier. If you're a Part A provider, I know we said that this was for Part B providers, but we may have some Part A providers in attendance. So if this occurs to you, you do have that option of adjusting a previously processed claim to add that modifier. So WPS does provide a resource on how to request a clerical error reopening. I've included a link on this slide. So, if you do find, oh, wait, we coded something wrong, or wait, we should have added that modifier, and you need to make a correction to that, then there is a reopening process. Here you're going to find a definition of a clerical reopening. There are some examples of what can and cannot be completed in this process. Here, I'll open this up so we can take a look at it. Again, definition. It's going to give you some examples of when you would do a correction through a clerical reopening and corrections that cannot be processed through a clerical reopening. It also goes over time limitations and then methods for submitting a clerical reopening. It can be done through the portal. This method allows users to receive immediate notification if the reopening was accepted. So that's, excuse me, one moment, sorry about that. It gives you methods that can be used. Like I said, the portal does give you that immediate acceptance, so you know if it was accepted. You can also request one through telephone. There's also fax or postal mail. So it does give you some information. If you request by telephone, you're going to need your PTAN, MPI, TIN, and claim details. There is information for submitting it through a fax. It has cover sheets provided. Notice that these are specific to jurisdiction, so that's something that you will want to um, make sure you're getting the right one. And then to submit it by mail, there is a link here for reopening the request form. So now we're going to go ahead and we're going to take a look at the NCCI tables. So let's go back to the CMS website. From the home page or from anywhere, we can click on Medicare, coding and billing, and then here we have the NCCI edits. We're going to look at the procedure to procedure. You'll also notice the medically unlikely and add-on codes are also out here. Here you can see where it is divided out. We have hospital edits, we have practitioner edits, and then they're further divided out by these code ranges. Again, I did download this ahead of time, so you are not waiting. So again, we got the column 1, which is the payable code, the column 2, which is the code that would be denied if a modifier is not allowed. Um, we have the existence prior to 1996, effective date, deletion date, modifier, and rationale. So to demonstrate today, I would like to use a pre-submitted question. During the registration process, I was asked, why will Medicare not pay for CPT 96127? Now, I can't give an exact answer because I cannot look at this provider's claims, but I can look at the NCCI procedure to procedure edits and give some possible answers. Since the 96127 is the code that is not getting paid, I am going to search for that in this column 2. So if I do a Control F, 96127, so here, and of course this all depends, like I said, I don't know exactly what the situation is that this provider was referring to, but I can see that if this is a code that's on the claim, here we have that one's deleted, sorry about that, so let's go. We can see that the majority of the time when 96127 is showing up, that modifier column is always a 0. So I haven't found anything just searching through this so far. I haven't found any codes where the 96127 is going to be allowed. So that would be one reason why the code could be getting denied. Um, you'll also see over here in the rationale, it says misuse of column 2 code with column 1 code. Now, according to CMS, this means that the description of the code listed in column 2 is similar or it overlaps the description of the code found in column 1. So that would be why this represents a misuse of the code, and that for that reason separate payment is not allowed. So again, that is just one explanation. I don't know exactly what's going on, but that is a way that you could use this tool to determine what's going on. Here, this is just another code pair. We can see that if we build the 96116 with code 90833, that would be allowed if the appropriate modifier is present. So again, just a really helpful tool to help you know when you're billing those codes, if they can go together. Now, I do want to take some time to answer some pre-submitted questions before I ask Mary if there's anything that's come through on the chat. And I'd also like to tell everybody, Mary has been covering mental health for a while. She's very good at this, so I have asked Mary if she has anything additional that she needs to add. She's going to jump in and she's going to give you guys that additional information. We really want to make sure that you get the best answers for everything that you are asking. The first question that I got was, what are the must-have modifiers and the must-have documentation? Now, this is really dependent on the services that were performed. So earlier we looked at the list of modifiers that could be used on the claim, and as you saw, it's all dependent on the services that are being billed. As far as documentation is concerned, you're just going to want to support that the services that were provided to the patient are medically reasonable and necessary. Now, if you are referring to a service that is found in our LCD, so let's go out there and take a look, because there are some different requirements out here. So let's look at WPS's LCD. Now, I'm trying to scroll a little bit slowly, so I know that bothers some people, so I don't want to I don't want to make anybody dizzy or anything like that. So if you are documenting psychotherapy services, this LCD is going to give you some of what the medical review department is looking for. The medical record must indicate the time spent in the psychotherapy encounter and the sorry about that, therapeutic maneuver such as behavior modification. I won't read all these to you, but behavior modification is not a separate service, but it's an adjunctive measure. Prolonged treatment must be well supported. To establish medical necessity of the service, claims must be submitted with a covered diagnosis. So here's a good place to look. If there is not something specific like that, then down here in the general information, there are general documentation requirements. So you're going to want to make sure that the documentation that you have supports the services billed and these 5 points that they're talking about. Um, so hopefully that will help. I can't give you a specific modifier or what I can give you as far as documentation is what the policy has listed. The next question I received is if a client is seen in the morning and calls in the afternoon and needs to be seen again, is it reported as two separate individual therapies with a modifier, and when would this be allowed? Now, I would start with checking out the NCCI tables to determine if there is an edit for those codes that you intend on billing. Then, see if the two services would be allowed if a modifier were present. You're also going to want to make sure to include information in the patient's medical records as to why they needed to be seen twice in one day. Did something happen that maybe triggered the need for another visit? And just make sure that this is shown because it can support medical necessity. The next question I got was what procedures can LCSW, LSW, RN, LPN code for, and what are the requirements? So for this, I want to talk about that MLN that we brought up earlier in the beginning of the presentation. This does provide a lot of information related to the mental health coverage, but one thing that I do want to show you here, if we scroll down to the table of contents, under the provider information, this goes through each of those providers and it provides information such as required qualifications, coverage requirements, payments, things like that. So let's take a look at one of the examples. Let's take a look at the nurse practitioner. So if we look at the nurse practitioner, it's going to tell you what are the required qualifications. And if you look under here under coverage requirements, it says you may personally perform diagnostic, psychological, and neuropsychological tests to the extent authorized by state law to perform tests. I won't read the rest of it, but here you can see that this does give coverage requirements. So that would be something that could be helpful since you are looking at specific professionals and what they can do. This would be a good resource to provide you with that information. I did get a question about billing the 90791 along with some testing codes and how many units would be allowed. Allowed units is something that you would want to look at for the medically unlikely edits table. So when we were looking at the Medicare for the NCCI, we do have these medically unlikely edits. So that would be something that you would want to refer to when you're wondering about units and what's medically necessary. And there is also, WPS has provided education on this. So that is something that you could look for in our YouTube channel and it could provide some more details for you. The next question I got was, why can't an individual therapy and an evaluation in management be billed on the same claim? Uh, there are, there is some information in our LCD. I want to go back up. Now, I don't know specifically what codes you are billing for, but I do want to show you. Again, excuse the strolling. Psychiatry services with evaluation and management. Some psychiatry services may be reported with evaluation and management services or other services when performed. So I'm not sure what you were billing. I don't know if you got a denial, but there are some services that can be billed together. The next question I got was 90837 and 90853 appear on the National Correct Coding Procedure to Procedure table. When looking at the edits, I'm going to kind of summarize this. There is a modifier indicator of 1, so this means they can be reported together. What would Medicare want to see in documentation to support these two services? So you are going to want to make sure that the documentation supported the need for the patient to receive individual and group therapy on the same day. Again, I'll bring you back to this because there is documentation requirements. So you'll want to look at the documentation requirements listed in this policy and then make sure that those are included in your medical records. The last question I would like to cover before I go to turn it over to Mary is a lot of times there's a crisis stabilization unit services directly for ER discharge. And as we've gone through these mental health series, I've seen crisis stabilization as a topic that comes up frequently. So on the CMS website, I'm just going to do a search for crisis stabilization, and we haven't covered this specifically, but like I said, it has gotten brought up a lot as we've been going through this series. Um, if you scroll down, they do have a page directly for psychotherapy for crisis. It talks about what's covered, who can furnish it, and how to bill. So hopefully this will provide you with the answers that you're looking for. Um, And, maybe that's a topic that could be brought up for future webinars. Just an idea there. But Mary, I am going to ask you if anything has come through in the chat. And also, again, feel free to provide any additional information or answer any questions.
All right, Karen, thanks for all of that great information. We did get just a couple of questions in the chat, but those questions that we received really don't pertain to what we've covered during today's session. They are or may be covered in some of our other mental health playbook sessions. But since we've not received any questions that do pertain to today's topics, I'm going to go ahead and answers to those questions. One of the questions that we received today, and it doesn't really pertain to billing same services on same day, is, and now I have to scroll, so please bear with me while I find this. A question is whether or not it is appropriate to use psychotherapy codes for substance abuse therapy, or should the H codes be used? So I privately asked the learner to provide me with a couple of examples, or an example of one of the H codes that she's referring to. And what I learned when I looked at the CMS relative value file, and Karen did demonstrate that earlier, I looked for H0001. That's an H code that my assumption is can be used for substance abuse therapy, which isn't a code that's in the policy that we talk about psychotherapy and psychiatry services in the billing and coding guidelines that go along with, or that are the companion article for that policy. I found that that H code is invalid for Medicare purposes. So, listen for it. But in response to your question of whether or not you can use a psychotherapy code for substance abuse therapy, in all likelihood, yes, as long as that information, or that service rather, is documented in your medical record. Can you point to and show in the medical record that it was psychotherapy? In this case, substance use therapy. So H code can't be used. Can a psychotherapy code be used? That depends. What is in that medical record documentation? Okay, so that answers the first question. The second question that I received is really a comment made by one of the learners. One area we cannot get good guidance on is LCAC. In a CMS inquiry, they stated MH counselor, which is a mental health counselor. I'm not really sure what an LCAC is. I would have to go out and look up that acronym. I'm not familiar with it off the top of my head. But the learner further stated that to me, an LCAC is not the same as a mental health counselor, and they're asking me to counsel. Oh, thank you, Chris. It is a licensed clinical addiction counselor. And I must tell you that and thank you, Mary, for many of the credentialed mental health providers, CMS kind of takes many of them, whether they're in LCAC or another certified or credential type provider, and they kind of, for lack of a better word, throw them into a category that is called by CMS a mental health counselor. So we don't individually enroll all of those provider types and assign them a specialty. Rather, we group them all together and we call them a mental health counselor. So that's the reason behind that. And for those of you that have been around a while, you may have noticed that, or you might know that two of the most recent additions to the CMS specialty list is a mental health counselor and also a marriage and family therapist. Okay, so we have MFTs. They have their own specialty code. That's a 2-digit specialty code that's assigned when that provider is successfully enrolled in Medicare. And we also have mental health counselors, which is also assigned a 2-digit specialty code by CMS. And mental health counselors, that specialty really has all kinds of credentialed providers that are kind of thrown into that category. So I hope that's helpful. And thanks to all of you who reminded me of what the LCAC is. Those are the only questions we received. Karen, I'm going to throw it back over to you.
Thank you so much, Mary, and thank you for providing answers to those questions. Now, when you disconnect from today's webinar, you will be directed to a CMS survey. I'm also having Mary add a link into the chat, and I really do hope that you will take a moment to provide feedback on how I did today. The redirect is going to look like what you see over here on the right, and we just want you to know we don't have control over how this appears, so we want you to know it's not spam, it's nothing malicious. If you are watching this as an encore, you will see this bottom image, which is the online survey with the stars, and that's what you'll see for that. Now, this feedback has actually led to changes. We started adding chapters to our encore presentations, so you can skip or go to areas that you really want to hear more about. We have training indicators in the descriptions of our webinars, and we've also held some Medicare education expos based on suggestions for future education topics. So, you know, your opinion really does matter, and we really do take what you say into consideration. Now, after disconnecting today, you should receive a thank you for attending email. That's going to contain contact hours that can be submitted for continuing education units. If you joined only by phone, WebEx is not able to generate this email, so we will need you to contact us. In the chat, Mary will add a link to the education mailbox and what information we need so that we can send you a certification if you need that. Now, if you do think of any questions, those can be emailed for up to 7 days following today's event. And we will take a look at that and respond to everybody. Now, that brings us to the end of today's presentation. On behalf of myself, Mary, and the Provider Outreach and Education team, I'd like to thank you for being here today, and I hope that you will join us for future events. You may now disconnect.